The next talk is a historical evolution of the microvascular decompression procedure for trigeminal neuralgia from Dandy to Jannetta. And it will be presented by Dr. Liu with co-authors Chowdhury, Kissner, Shukla, Applebaum, and Liu.
Thank you. My name is Osama Chowdhury. I'm a fourth-year medical student at New Jersey Medical School, and I just want to thank Dr. Liu, my mentor, for allowing me to present this talk. So what I'll be discussing today, the topic is the historical evolution of the microvascular decompression procedure as it evolved from Dr. Walter Dandy to Dr. Peter Jannetta. So trigeminal neuralgia, it's a disorder that I'm sure most in the audience are familiar with. It's been described as one of the most painful afflictions that one can experience. The earliest description is thought to have come from the ancient Greeks in the 1st century AD. And ever since then, all learned civilizations have typically had a description in one form or the other in their works on trigeminal neuralgia. But the root cause itself has eluded physicians and scientists for hundreds of years. Real progress on the surgical treatment of trigeminal neuralgia wasn't really made until the late 19th century, and it was then that the trigeminal nerve itself and the Gardner ganglion had been identified. And one of the first established surgical approaches was courtesy of Dr. Frank Hartley and Dr. Fedor Krauss, who are pictured on the right, in 1891. And what they described was a subtemporal extradural approach to the Gardner ganglion and performing a ganglionectomy. 10 years later, Dr. Charles Frazier and Dr. William Spiller of the University of Pennsylvania, they modified the approach to not target the ganglion, but to instead target the sensory root of the trigeminal nerve posterior to it and section that instead, thus sparing the motor root damage. By 1921, 2 decades after they developed or modified the Hartley-Krauss approach, Dr. Frazier had declared trigeminal neuralgia as a problem that had been solved surgically. And he quotes as saying, "Apart from our ignorance as to the etiology, there's little left to the investigative mind." Despite this, significant complications still remain. It included motor root damage, facial numbness, and in certain cases even hemiplegia and epilepsy. Here's a beautiful illustration showing the Hartley-Krauss approach, and here we see the temporal lobe is retracted superiorly, and there's a nerve hook around the sensory root of the trigeminal nerve. Dr. Dandy, at that point, he was a professor of neurosurgery at Johns Hopkins University, and at first he was quoted as saying on the Hartley-Krauss operation that there have been fewer greater triumphs in surgery than the Krauss operation as it's developed in its final form by Spiller and Frazier for the permanent cure of one of the worst afflictions mankind has been faced with. And however, Dandy, being the perfectionist that he was still troubled by the complications experienced by patients who underwent the Hartley-Krauss procedure. And in the mid-1920s, he started developing his own approach. Specifically, this approach was a suboccipital, and he titled it a cerebellar approach. And it was an intradural approach through which he wouldn't just perform a section of the complete sensory root of the trigeminal nerve. Instead, he'd spare most of it and just section the posterior lateral portion, which he felt carried the pain fibers. His patients, upon waking up from the operation, never experienced the complications, the serious complications that the Hartley-Krauss approach patients experience, including the motor weakness, facial numbness, and the epilepsy. Here's an illustration demonstrating and contrasting the two approaches. On the bottom, you see the Hartley-Krauss approach to the temporal route, and on the left, you see Dr. Dandy's cerebellar route. And Dr. Dandy particularly liked his approach because the point at which he reached the sensory root of the trigeminal nerve was the point at which it was farthest away from the motor root of the trigeminal nerve, and so he was able to protect it. He felt better than the Hartley-Krauss approach. Here's a craniotomy that he performed, the suboccipital craniotomy. Usually it was a 7 to 8 centimeter U-shaped incision, and postoperatively, once the patient's hair grew back, it was hidden pretty well. And here we see how Dr. Dandy sectioned the posterior lateral portion of the sensory nerve root. And he's using a nerve hook here with with teeth, and he'd just select that portion and delicately section it, thus preserving the motor root and the majority of the sensory root. And so these patients had facial sensation and motor function postoperatively. By 1929, he had published his first 88 cases of the procedure. He declared a cure for trigeminal neuralgia, and he started noticing some peculiar things even in his earlier cases. He'd see, typically in 2 or 3 instances at first only, that an arterial loop would at times be encircling the sensory root. And it's particularly impressive that he made these observations without the aid of a microscope or modern surgical lighting. He only made them with his own vision. In 1932, he had published 250 consecutive cases, and by then he felt as if these observations of arterial loops, venous branches, and even tumors near the sensory root when he performed the operation weren't just a coincidence, and perhaps they might be related to the cause of trigeminal neuralgia itself. In 1934, he published a paper in which he demonstrated an understanding of trigeminal neuralgia really far ahead of his time. And in this paper, he did a retrospective review of 250 cases in which he personally wrote the operative notes. And he found that in 60% of these cases, he'd see some sort of either gross lesion, arterial compression, or venous compression. And there in the box is, in 30% of the cases, he noted an artery on the nerve. And again, I really can't stress how remarkable these observations were. And not the fact that he just made these observations, but that over time he was able to synthesize them into a hypothesis regarding the cause of trigeminal neuralgia. In that same paper, these are some, again, beautiful illustrations showing what he experienced in several cases. And here we see the superior cerebral artery lying over the sensory root. Here we see an ectatic basilar artery, and on the right we see venous angioma lying over the root as well. And he even documented the course of the petrosal vein itself, and at times how it would also put pressure on the nerve root. So Dr. Dandy, he never tested his hypothesis out regarding compression of the trigeminal nerve root. And the way to test that would have been that he goes, and if he notes a vessel compressing the nerve root, he would just decompress it and close and see if the pain was relieved. Instead, he would always section the nerve root. And over time, his cerebellar technique itself really fell out of favor, despite the fact that it had fewer complications than the Spiller-Fraser approach. And one of the theories, and this was put forth by Dr. Pincus from Pittsburgh in the 1980s, was that at the point where Dr. Dandy introduced his procedure, it was a critical juncture for neurosurgery as a specialty, and they were trying to establish themselves separate from general surgery and trying to show themselves as a legitimate specialty with procedures to be offered to the general public. And so the mainstream neurosurgical community, they rallied around the Spiller-Fraser approach, which had more political power behind it and was more quote-unquote established. And it didn't help that Dr. Dandy at this point in his career was alienated from Dr. Cushing, whose political power was put behind the Spiller-Fraser approach. Dr. Dandy's untimely death in 1946 and the fact that he really didn't have residents and trainees that had the political power to keep his hypotheses and his approach at the forefront of neurosurgical thought all contributed to the failure of his approach and hypotheses to really be accepted. Here Dr. Gardner would later say, on reviewing the evidence on the history of Dr. Dandy's approach to trigeminal neuralgia, that he felt it was unfortunate that his view wasn't accepted, and it's difficult for him on any basis to explain the basis on which Dandy's views, the universal rejection of Dr. Dandy's views on trigeminal neuralgia. So Dr. Dandy's compression hypothesis didn't really come back to the forefront of neurosurgical thought until 1951 when a Danish neurosurgeon, Dr. Tar-Haj, who had trained under the master European neurosurgeon Dr. Ola Krona, made a kind of fortuitous observation in one case. He was operating in 1951 on a 31-year-old mechanic and he opened up the patient, and he saw that the patient had presented with classic signs of trigeminal neuralgia, and he opened the patient up using the subtemporal route, and he saw that a epidermal tumor was compressing the nerve root. And what he did was he took the tumor out, but he did not section the nerve root. He just closed the patient up, and the patient woke up free of pain. And it's during this operation that he says the idea arose that maybe the cause of trigeminal neuralgia could be found in compression of the nerve root. His hypothesis as he developed this approach, after he gained more experience, was that perhaps trigeminal neuralgia was caused by pressure being put on the sensory root by a bony ridge, particularly the petrous ridge. In 1954, based on this observation, he developed an approach in which he would perform an incision of the dura over the posterior root to decompress it. He demonstrated this approach in 70 patients. Initially, they did well, but over time, there was a high rate of recurrence, and his procedure never really caught on. But what his procedure did do was that it inspired Dr. Gardner. And Dr. Gardner himself, he trained at the University of Pennsylvania under Fraser and Spiller, who had the previous approach, which was competing against Dr. Dandy's approach. And so it's obvious where he developed his interest in trigeminal neuralgia. And after he finished his residency that same year, Cleveland Clinic had a major disaster. A bunch of X-ray films in the basement of their outpatient clinic caught on fire. The entire building burned down. 123 people, including many famous physicians there, and their only neurosurgeon, Dr. Locke, passed away. And Dr. Gardner was recruited to the clinic to take over and establish the Department of Neurosurgery. And he took an early interest in Dr. Tar-Haj's approach, himself began to experiment with decompression techniques. In 1959, with Dr. Milkos in Cleveland, he published a landmark paper in which he also had a method for decompressing the nerve root and manipulating it to free it of compression. And he compared that to 100 patients operate through the Tar-Haj approach. And it was in this paper that he described the microvascular decompression. This is the first time microvascular decompression procedure was ever described. And he noted that in one patient, an arterial loop was found around the nerve. He put a piece of gel foam in between the artery and the nerve, and he closed the patient. The patient woke up free of pain. So he was the first neurosurgeon to perform the microvascular decompression procedure. And in other cases, he also at times noted vascular decompression. He felt that what happened with this compression was that an artificial synapse would be created in the trigeminal nerve. Even though he noted vascular compression in several of his cases, like Dr. Dandy, he was limited by not having the operative microscope. And so he couldn't really visualize the entire dorsal root extensively. And so at the time, he wasn't able to change the paradigm regarding trigeminal neuralgia, which still was that it's caused by an intrinsic problem in the nerve root itself, and the only way to cure it is to section or destroy the nerve root. And it would be Dr. Peter Jannetta who would come and change this paradigm. And Dr. Janetta, he started off his career as an NIH research fellow at University of Pennsylvania. He spent extensive time under the microscope back when it was just first introduced for delicate operative procedures. And he worked up to 30 hours straight with a microscope, and over time, this was before he was even a resident, he was convinced of the fact that the microscope was necessary in the operating room. He moved to UCLA for his residency in 1963, and 6 years earlier, Dr. Theodore Kersey at USC had become the first neurosurgeon to use the microscope intraoperatively. And Dr. Kersey had used it to operate on vestibular schwannomas. So when Dr. Janetta arrived in Los Angeles, his colleague Dr. Rand in the department allowed him to use his microscope, and he'd use this to practice dissection of the cranial nerves on cadavers. Over time, he developed a specific approach, kind of perfecting Dr. Dandy's approach with the use of a microscope. So he showed this approach to the faculty at UCLA, and in his words, he was forbidden to operate at the main teaching hospital, and especially using this retromastoid approach he had developed, because in the pre-microsurgical era, it was thought it was too dangerous to be in the cerebellopontine angle. So what happens is that one night, a classic case of trigeminal neuralgia presents at an allied hospital, and Dr. Jannetta takes Dr. Rand's microscope with his permission. He loads it in his 1957 Ford station wagon, and he goes over there, and he operates on the patient. And during the case, he found the superior cerebral artery compressing the trigeminal nerve. And right then, intuitively, as he puts it, he thought it to be the cause of trigeminal neuralgia. For him, this was, quote-unquote, a magic moment. This would be a 1957 Ford station wagon, probably not the same color, but same model that Dr. Jannetta used to transfer that microscope. And here we see, after at least 5 to 6 more cases, he each time noted tortuous arterial vessels compressing the trigeminal nerve root. And here he published his findings. This is one of his first papers, and one of the first papers showing microscopic pictures from the operating microscope demonstrating arterial compression of the trigeminal nerve root. So he continued to operate. He was convinced that he had found the cause of trigeminal neuralgia, and he even saw this in patients with hemifacial spasm. And again, the microscope afforded him a level of detail which Dr. Dandy and Dr. Gardner never had, which brings their observations and kind of puts them as being brilliant in their own right, that they were able to observe that without the aid of such a useful tool. And Dr. Jannetta's vascular compression hypothesis initially wasn't readily accepted. He was a young resident at UCLA, and he says, he's coming out saying he's figured out the cause for trigeminal neuralgia and the operation to cure it. And those in the mainstream neurosurgical community really didn't take to him favorably. Once they realized that microvascular decompression was a good procedure, they accused him of stealing it from Dr. Dandy and Dr. Gardner. But despite this criticism, he continued to perform hundreds of MVDs, especially after residency when he went to New Orleans and later to Pittsburgh. Here, his own colleague, Dr. Rand, was disturbed that the procedure, microvascular decompression procedure, at the time had been called the Jannetta procedure, and he wrote an article detailing that it should be called the Gardner procedure because he was the first to describe it. So Dr. Jannetta, he in many ways experienced resistance the same way that Dr. Dandy had, and he was fighting against a paradigm. He was a young person fighting against a paradigm which had been established for over 6 decades. And again, there was something, the paradigm was that there was something intrinsically wrong with the trigeminal nerve itself, and the only cure was to damage it. And as he puts it, the issue with him was that he was a young, smart-ass finding the cause of trigeminal neuralgia, and the community reacted the way they did because it was too much for them to bear. As one critic put it, you can't cure trigeminal neuralgia with a little bit of fuzz, which would have been the Ivolon or Teflon sponge he used to perform the procedure. He continued to perform the procedure, and over time, this is a landmark paper in 1996, which demonstrated over 1,100 cases where microvascular decompression was shown to be effective and safe for the treatment of trigeminal neuralgia. A quote from him, from Dr. Jannetta himself, kind of sums it up well, and he says, "It takes 20 years for anything new to really catch on, not because it takes that long to convince the establishment, but because it takes that long for there to be a changeover to people who have grown up with this new idea as being accepted." So in conclusion, Dr. Dandy, Dr. Gardner, Dr. Jannetta, they all faced significant opposition from the mainstream neurosurgical community when they were challenging established views on cause and treatment for trigeminal neuralgia. And Mr. Shelton, who wrote a book on Dr. Jannetta, probably sums it up best in that Dr. Dandy may have understood principally the same thing regarding the vascular compression hypothesis, but it was Dr. Peter Jannetta who managed to get the rest of the neurosurgical community to believe it. And today, microvascular decompression remains an effective treatment in trigeminal neuralgia and other neurovascular compression syndromes. Thank you.